much, sir. Can I share screen, sir?
Please, sir. Please.
So, are my slides visible, sir?
Yes, sir. Your slide is visible. If you can just go on the slide.
Okay.
Yeah,
Right,
visible, sir. Loud and clear.
Thank you so much, sir. Good evening, Dr. Harbans, sir, Dr. Avninder, Dr. Vinod, and all the other speakers and panelists. I'm thankful for the opportunity. I'm going to talk on recent advances in pharmacotherapy for glaucoma management. And we all know glaucoma is a chronic progressive optic neuropathy leading to damage of optic nerve with loss of vision, and the most common modifiable risk factor is raised intraocular pressure. Glaucoma is a growing concern, and it's the leading cause of irreversible blindness globally. 80 million people have been affected by 2020, and this is an increase of about 20 million since 2010. And this figure is expected to increase up to 112 million. That is an increase of by 2040. And this is going to majorly affect the Africans and Asians. So what is the scenario in India? 12 million people affected, of which 1.2 million people are blind from the disease. And unfortunately, more than 90% of these cases remain undiagnosed. Let's talk about chronology of anti-glaucoma drugs. The first anti-glaucoma drug which made its appearance was way back in 1875, pilocarpine. It took almost 100 years for beta blocker to make their entry in the form of timolol. Then after that came carbonic anhydrase inhibitors in 1990s, and then prostaglandin analogues. And the last drug which made its appearance was prostaglandin analog was 2014 cafluprost, and in 2017 we had drugs by the name of ROCK inhibitors. So where is the need for newer anti-glaucoma drugs? One, to improve the health-related quality of life. We want drugs which also offer additional neuroprotection. And if the patients have known allergy or side effects to the existing drugs, we want drugs with longer half-life, which are more potent with lesser side effects. And there is a need for preservative-free drugs. Also, we need economical drugs and drugs which also improve patient adherence and compliance. So we have some drugs by the name of latanoprostin bunod. We have ROCK inhibitors. We have combination of ROCK inhibitors with prostaglandin analogs. And if we classify these drugs like innovative hypotensive drugs in the form of ROCK inhibitors, we have A1 receptor agonist, small interferon RNA, cannabinoids, latinculin derivatives. Then we have some antioxidative agents. We have neuroprotective agents. And also in the pipeline are neurotrophic agents like ciliary growth nerve factor and many other trophic nerve factors, besides gene therapy, etc. So what is, if we talk on what is new in the medical management, there are publications on latinculin B, which reduces intraocular pressure. It comes in the percentage of 0.005%. And this publication showed that it causes mean reduction in intraocular pressure of 34%, almost as much as prostaglandin analogs. Then we have nitrogen monoxide donors. See, synthetase is mainly found in anterior segment and non-pigmented epithelium of the ciliary processes. Nitrate oxide donors, they usually have action in the form of increasing the outflow, conventional outflow by relaxing the trabecular meshwork cells, and they also increase the uveoscleral outflow, besides increasing and promoting the retinal ganglion cell survival. So latanoprostin bunod comes in the percentage of 0.024%, and the IOP reduction occurs as early as 1 to 3 hours after first dosage, and the effect lasts for about 12 hours. Studies like Lunar and Apollo have demonstrated its non-inferiority to beta blockers, and another study like Voyager has concluded that latanoprostin bunod had better IOP reduction than prostaglandin latanoprost. And the prostaglandins we all are quite familiar with. Prostaglandins, the effect of prostaglandins was reported in the year 85, and the first prostaglandin which was approved by FDA was latanoprost, then came bimatoprost and travoprost. And we have various receptors for prostaglandins, 9 types of receptors to be precise. And these are PGFP receptor, PGE1 to 4, PGD1 to 2, and thromboxane A2 receptor. PGFP and PGE are 2 main types of receptors present in human eyes. And so what do we have future developments in prostaglandin analogs? The only drugs approved by FDA right now act on PGF2 receptors. And current research strategies are focusing on developing compound that can also target PGE2 and PGI2 receptors. Latanoprostin bunot, I've talked about, is a nitric oxide donating PGF2 analog. Sulprostone is PGE2 receptor agonist. Prost and dinoprost are again PGE2 agonists, iloprost PGI2, and then we have drugs like DE117 and ONO9054, which are undergoing phase 1 and phase 2 trials respectively. We have also drugs which are sustained release implants known as bimatoprost Durasta implant. It received FDA approval in March 2020, and it delivers drug over 4 to 6 months. We also have travoprost intracameral implant, and this also has a longer duration of action. So the problem of patient adherence and compliance will be taken care of to great extent, besides promising a great efficacy of reduction of intraocular pressure by more than 30%. We have the technology in the pipeline where we can detect apoptoizing retinal ganglion cells, and this is a novel technique which holds potential as a surrogate marker. We right now have only pre-perimetric glaucoma diagnosis by various imaging techniques. But imagine if we have a technique where we are able to detect the apoptoizing retinal ganglion cells, then we can really initiate the treatment at a very early stage and prevent the apoptosis of retinal ganglion cell in these subgroup of glaucoma patients. So the targeting apoptosis, we interfering with the apoptosis cascade through of genes or their protein products can have a neuroprotective effect. And there is a mouse cell line expressing BCL2, which is a apoptosis inhibitor. So trabecular meshwork is a favorite tissue for gene transfer. We have a glaucoma association of genes like caveolin 1, caveolin 2, angiopoietin like 7, etc. genes have been identified. Then increasing neurotrophic factors is also very important, and these can have potentially play a great role in the management of glaucoma, like neurotrophic factors for retinal ganglion cells, and intravitreal injection of neurotrophins such as neurotrophin 4 is being studied. Then what is the problem with IOP lowering medication? Of the currently available medications address the underlying pathology, that is increasing the outflow resistance. See, beta adrenergic antagonists and alpha 2 adrenergic agonists do not lower intraocular pressure during nocturnal period. Many patients are unable to tolerate, and even when all the 4 agents are used in combination, IOP lowering may not be sufficient with maximum medical therapy. So need of the hour is to have an agent which have a novel mechanism of action which directed at lowering the main pathogenesis, that is decreasing the outflow resistance. And which is also equally effective during both diurnal and nocturnal periods, and has additional pharmacological properties that support the retinal function, and which is well tolerated with minimal side effects. So that's how these ROCK inhibitors appear to be very promising, because Rho is a group of small GTP binding proteins. And what does is it increases the conventional outflow at a subcellular level. We are all familiar that how aqueous outflow occurs through the various parts of the outflow channels. We have the conioscleral, juxtacanaluclear pathway through which it goes into the Schlemm's canal and through the aqueous veins. So ROCK signaling has been identified as the important regulator of trabecular meshwork outflow, and ROCK sensitizes smooth muscle in a calcium independent manner. What it does is the actin polymerization and actomyosin assembly, it causes the ROCK functions is it causes contraction, cell addition, and extracellular matrix organization. So ROCK inhibitors are going to counteract all these contraction, cell addition, and extracellular matrix organization of the smooth muscle cells in the pathway. And so they act at subcellular level. How these act? This is the actin-myosin assembly of the proteins, and by the contraction of this and localization at the tip of the trabecular meshwork cell, you will find that this actin-myosin complex assembly causes the trabecular mesh cells, and what it does is it will increase the pore size of the outflow channels of through the trabecular mesh pathway, thus decreasing the outflow resistance and increasing the outflow passages. To understand, we must know what are GTPases. GTPases are molecular switches, and it is considered on when it is bound, Rho is bound to GTP, and off when it is bound to GTP. So Rho is activated by binding of GTP. It leads to activation of ROC. So role of ROC pathway in pathogenesis of glaucoma is now very well documented. They have been linked with the control of cytoskeletal dynamics, ectomyosin contractile forces, cell adhesion, extracellular matrix reorganization, and cell morphology. So ROC inhibitors, besides decreasing outflow resistance, they also offer neuroprotection of the retinal ganglion cells and also increases the retinal ocular blood flow. You'll find that by the ROC action, they enhance intraocular pressure, they may cause scar formation, they may cause retinal ganglion cell apoptosis. But if you give ROC inhibitors, they will counteract these effects by stopping increase of intraocular pressure. They may also modulate the scar formation and in fact decrease it, and also increase the ocular blood flow and decreasing the retinal ganglion cell apoptosis. So these drugs are in the form of ripasudil and nitarsudil. And it has been found that these drugs offer us a novel mechanism of action and also increases the possibilities and more drugs for us in armamentarium to treat glaucoma. So future looks exciting. Currently, lowering of intraocular pressure remains the only treatment strategy. We now have sustained drug delivery systems, and for future personalized medicine that considers individual variability in genes, environmental and lifestyle factors for each person, and thus it holds a promise to predict optimal treatment and prevention strategies for individual glaucoma patients. Then we have drugs like cannabinoids, topical agents, which can lower intraocular pressure. We have drugs like melatonin, and in fact, topical agomelatin, which has been found to lower intraocular pressure by 30%. We have connective tissue growth factors, we have adenosine, and so non-IOP dependent treatment strategy in the form of neuroprotection can also help us in the management and treatment of glaucoma. So neurotrophic factors, I will not go into the details, where we have various types of neurotrophic factors. And these all drugs can help us besides calcium channel blockers, nitric oxide synthetase inhibitors. And so these drugs can really help us. So the future of medical management of glaucoma seems very exciting. And I'm not very sure, but if we really have all these drugs into our armamentarium, I don't know whether we'll really feel the need of having surgical management of these glaucoma patients. Thank you everyone for your kind and patient attentive hearing.